This is perfect for a sort of cozy discussion type thing, so I'm going to be very informal. For those of you who don't know me, I'm Rob Dennis. I'm a GP in Listowel, Ontario. I work today actually, and I'm on track out here, thinking that the hurricane might keep me away, and I'm watching the movie right now. But it was actually pretty nice, so I wasn't disappointed. No, it's good to be here. And I'm the primary care lead for the South West LHIN and the co-chair of the I gotta keep moving. Co-chair of the South West Primary Care Network. I'm going to go around the table and just introduce yourself. And if there's something you're really wanting to get out of this particular talk, just so that I can get there, then let me know. My stated goals, or what's I've been asked to do, is to really provide an update on where the LHIN is going, and sort of by proxy where the province wants us to go with primary care, what that might look like, and I can tell you right now, in the province of Ontario, there's not a lot happening, although apparently there are negotiations happening, which surprises all of us, but there's not a lot happening. So some of the legislative changes that might be necessary to move some of this stuff forward probably will come in for a little while. So a lot of it's still in model theory, and so it's actually good to be input right now. But, so I was going to talk about the potential hub models, some of the stuff the LHIN's doing to support primary care, what they could be doing, and the primary care network, which was referenced this morning, a little more specifically what we did in our first year and where we're going with that. So those were what I was going to be talking about. But if there are other things that people have in mind, I really like to know what they are, and I would really get a sense for who's around here. So, and that's really what this is about, actually. So the primary care network and the hub model are ways of engaging groups of physicians in the planning and development of the healthcare system in a meaningful way, because we know this from Cancer Care Ontario, that when you engage clinicians in the planning of the system, things work. You have to have that frontline input into how it works. Otherwise, you make a great program, you roll it out, and no one uses it because it doesn't work. So, it makes a lot of sense, and that's really what this is about. Okay, this is the Integrated Health Service Plan, or at least one iteration of it that was in development. That's the 3-year plan that Mike was referencing, 2013 to 2016. And I think if all you take home tonight is this slide, then you're doing well. No, just kidding. It's impossible to read. But I'll focus in on the first arm. And this is actually the cool thing for primary care docs, is that the LHIN is really, and the province is really keen to be about primary care. And actually, you heard Mike Baird say, it's the basics. And I think people are finally coming around to realizing that. And the studies, international studies support this. If you have a really good primary care system, you have better patient outcomes for less cost. And if you really push the specialist hospital system, you have a very high cost system with poorer outcomes. So, primary care is the key thing. You have a really good primary care system, and to get that, you need to have people involved in the discussion how to get there. So, in particular, what does the LHIN have in that arm? And he went over it a little bit. Increasing timely access, integrating family health care as the first point of contact for people with complex and chronic conditions, increasing access to local and LHIN-wide interdisciplinary teams, facilitating access to community services and supports, and diverting avoidable ER visits. So what does all that mean for us? So what I did was I put those, this is the animated part of the program, I put those 5 things here, and I'm going to put it on the, now this is the LHIN slide, I'm going to change this into the provincial slide. So we move that one down, and that one down, and that one up. And then we have the provincial directions are access, quality, and accountability. So this is how I actually think of my job. So the improvement of primary care with the support of the LHIN hopefully increases access to primary care, increases the quality of primary care, and involves accountability from primary care organized in a hub model. That's what the province wants to do with all those various excellent care for all act, blah, 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 that are out there. These things presently are part of what we do. GPs in our LHIN do a great job. But we all, at this point, in terms of accountability, we are accountable to the patient. So if you have a patient in there with something and then you do your job, if they don't like what you do, they can complain about you, and then there's an accountability mechanism there. We don't actually have accountability mechanisms to improve access into our practices or to improve quality in our practices. And there's all sorts of quality measures, and to be honest, I think we actually do a good job. But for instance, they say only 1/3 to 1/2. I think of evidence-based guidelines are met in primary care in Canada, but there's about 800 guidelines. And how can anybody implement 800 guidelines? Like, it's ridiculous. And so the new vascular collaborative that's coming out of the province, for instance, is trying to dump all of those into something that's usable by primary care that we can actually, work towards to get people to guidelines. But we don't have to do that. And that's one of the problems in terms of the lack of accountability. We don't have to improve the quality we're giving in our practices. Not that we're doing a bad job, but we don't even know, to be honest, a lot of the time, although we're getting better at that. So, interrupt me anytime, but I will be coming to these things sort of as we go. Just a snapshot of primary care in our LHIN. We have about 800 family physicians, and this is what I'm speaking to in terms of getting input. So they're all basically in their own office doing their own thing, or in their own group doing their own thing. They're not connected. It's not a primary care organization. It's a bunch of primary care physicians. If you have a program, if you have a new cervical screening program, new diabetic program, CCAC has a new wound care program, we have a palliative care issue, and how do you connect with all these people to make it better? And we don't have a good system. 800 family physicians, taking care of about 1 million patients. In that, we have 20 family health teams, and they're spread out, the little orange dots show you where the family health teams are. It's not quite representative because the Thames Valley Family Health Team, which is there, is actually quite huge. So a lot of them are really big, so the size of the dot isn't taken into account there. And then 5 community health centers, 2 nurse practitioner clinics, and the enrollment numbers are interesting. So in our LHIN, 78% of the patients are enrolled in one of the primary care models. So that includes the bigs who enroll, FINs, FOs, not FINs, but FITs.
Bigs are part of that then?
Bigs would be part of that. Well, if they enroll. 78% of the patients are enrolled, because bigs don't have to. And the purple, the dark purple is where there's a lot of enrollment, and the light purple is where there's less. So the interesting thing for me was that in the rural areas, most of the patients are enrolled, and in the urban area of London, we have 2 systems. We have the urban and we have the rural in Ireland. It's interesting. There's lots of different issues always. They approach things differently. I was going to tell you something else really interesting about that, but I lost it. So one of those 5 things was to increase access to interdisciplinary teams. So you know that we have, like I said, 20-odd family health teams, and we have a bunch of community health centers. So those physicians working in those practices, those patients in those practices have access to all those team members. The rest of the LHIN doesn't have that. It's not a fair situation for the physicians or for the patients. We're unlikely to get more teams being funded by the government. Not that they don't think it's a good idea, although they wonder because our enrollment models in the team-based practices didn't go up as much as the government was hoping. So they were disappointed by that. But also, they just can't afford it right now. So we're not getting more teams. So is there a way for the LHIN to maximize the use of the allied healthcare professionals over there and a lot of the expertise that exists over there to help out the guys who go the wrong way, help the guys that way? And actually, you might have a focused practice person who has a real expertise in dermatology or sports medicine or something on that side who could help this way. So it does go both ways, actually. I didn't mean to say that. But this is not a tolerable situation, and we really should be doing something to improve that. It becomes a risk factor for the bigger family health teams because we're talking about sharing the resources. The enabler of all these things, in my opinion, is this primary care network. How many of you have heard of this? Or haven't? Yeah. So this is a network model. So what that means is we have a network. We meet with our 10 people. That's 8 doctors and 2 nurse practitioners from LHIN, and then they're paid to go and meet with the next level out. So they're supposed to go out locally. And that locally may be their hospital group, their research group, their email group. So maybe it's not necessarily all geographical, but it's a diffusion model of connecting to primary care and bringing stuff back. So as opposed to emailing everybody or running the CME event or having a dinner, you're actually having good discussions, consultations with primary care about the various issues. some of you may have seen this graph of, you can inform people in terms of connecting to somebody, you can inform them right over to empowering them to do something. So we're right along that whole, we're trying to be right along that whole spectrum. And we say we're the voice of primary care in the Southwest. The $60,000, by the way, was raised from the LHIN, the OMA, CCAC, and the cancer program. So it's not a LHIN, this is not a LHIN, the network is not owned by the LHIN. It's supported by the LHIN, but it's actually, we say we're owned by primary care. And we have a selection committee to choose who sits on it. We're co-chaired by myself and Lord Schachter, who's the diabetic. We say that we are there to be the primary conduit for regional programs and organizations to engage primary care. So, Donna would speak to this. They might have something new that they really want to know what primary care thinks about it, or they're going to change the form or something. Well, now they have a place to go to bat at. Or if we're really bugged, because, for instance, we said to them once, we don't think a lot of the palliative care home care nurses actually have enough training to be doing this, and that's something you guys should look at. So, we have this conversation back and forth, and there's a mechanism or a structure to do that. This is where all our members are from. So we have members right from Lion's Head at the top down to, oh gosh, where is that? St. Thomas? Oh, that's St. Thomas. Dunelm, Westmoreland, yeah, Dunelm. Queen Anne's Center, that's George. Down the bottom. So we have members from all around. We have geographical representation, plus we have fit, faux, fin, non-enrollment model representation. So we tried our best, and this was the selection committee who did this, to pick people to represent the breadth and geography of the LHIN. So 8 family doctors, 2 nurse practitioners, 2 co-chairs, and representation, urban, rural, and the various models. So we've been in existence. We were initially in existence as a primary care and cancer network. For a year, that worked into the primary care network. First year was last year, and then now we're into our second year. We just finished a strategic planning day. These are some of the people we talked to in our first year. I won't go through them all, but the Diabetes Cancer Program, the LHIN, Health Quality Ontario, and this was a two-way consultation. So we were giving input. Sometimes we asked them to come, sometimes they wanted to come. So it goes both ways. And in fact, next door, what's happening, which is the issues around referral, that came from these guys. So these guys said, as soon as we sat down, the first thing they said was, we hate the way the referral system works. There's lots of problems, it's got to be fixed. And of course, we know it's a problem, it's why a problem. So first we went and talked to the OMA, and actually I almost got booted there, but no, it wasn't that bad.
It wasn't that bad. It wasn't me.
But then actually, then taking over next door or something. But then we did a little thing, so we changed the colonoscopy referral program in London by making it so that you could use your EMR instead of paper. And we got a centralized referral thing going there. And we started to look at what Champlain with Ottawa is doing with e-consults, so the email consults, and that's why they're all here now talking about. So that actually came from the network. And it's a problem, but and actually Ontario is looking at it, which is good. So we've engaged all these groups. But then what happened was, as I said, it was supposed to be a diffusion thing out, and the guys who were supposed to go out and talk to their local groups didn't really know what to talk about. And we were a little bit lost at the start. So we decided to come up with 5 specific goals, doctors, action-oriented. So our 5 goals were to roster 100% of the orphan diabetic patients in our LHIN, increase the rate of colonoscopy after a positive fecal occult blood test from 60 to 80%. So this is an unbelievable stat, of course, that if someone does a screening FOBT test and it's positive, which means you have a 10% chance of cancer, only 60% of those people had a colonoscopy within a year. 40% didn't. But CCO didn't know why. Well, that's crazy. Like, if you had a 10% chance of cancer, you're not following up. So CCOs working very hard to do that, so we were going to try and assist them to get that rate up. And improve the referral system, so that's happening next door. And encouraging partnering for quality. I don't know if people know what that is, but quality improvement initiatives in the office take lots of effort. Usually a team, and it can be a virtual team with the CCAC involved. So partnerships for health, engaged CCAC, team members, physicians, all sorts of practices, and they try to improve diabetic care. I think most of you guys know this. Really good outcomes. And the LHIN wanted to continue to support primary care in this quality improvement initiative, so they moved to what's called Partnering for Quality, and that's where these folks are coming in. In fact, Gina's the e-health coach. Is that fair to tell? Who goes around to practices when they're having struggles with getting data out of their EMR, and she will come and back to LHIN and CCAC and help us. So there's support there. Now they've hired one more coach now, who's Andrea. That's Andrea, who will come out and support you as you try and do a quality improvement initiative if you like that support. So we're pushing that still, and then encouraging open access scheduling, which actually is turning out to be quite a fascinating thing in the province as well, because of so many various ways of implementing. It's not so much anymore that this is a good idea. Everybody agrees this is a good idea. It's more that everybody's doing it differently, and sometimes it actually makes things worse. And so there's all sorts of issues around how you do this. You know, if you're working in a merge and hospital and OB, so you're in the office 2 or 3 days a week, can you really be expected to do 24-hour appointments? And that's where the province, by calling this 24-hour access, has really screwed a lot of sort of things. And can you cut that out?
Got it.
It's not 24-hour access has made people stuck on 24-hour access, and it's not really about 24 hours. It's about access. I like the term open access so much better. It's about access. So, and again, it's how you implement that. And we can talk about that a little bit if you like. So, but that was actually a goal that came from this group. And that was before I was the LHIN lead. That didn't come from me. That came from the primary care doctor saying, the guys who do open access, they loved it, so we should get this everywhere. That's where that came from, on this list. And that was actually made my job really easy as the primary care lead, because I came into the job after these were made, and the last 2 are the ones I'm supposed to do. So the primary care network was trying to do it, which is great. Okay, so just a few on each one of those things. The poor patients who aren't adopted have it rough, people with a family doctor. And the goal, the network said, how can we actually help with this? Because we don't want to be too big, and that's just a chronic disease thing. You make small changes. And because we had the diabetic agenda on board, we decided what we would do is try and not roster everybody in the LHIN who didn't have a family doctor. It was 16,000 at one point, it's about 4 now, I think. But to just focus on that population of diabetic patients who don't have a family doctor and try and roster them. And in January of 2012, there were 199 of those patients around the LHIN. We knew we had 800 doctors, so if we said to every doctor, take one of these diabetic patients, we knew we could get rid of that list. But right away, we ran into all these barriers, and physicians have some really good issues with Healthcare Connect. So for instance, there's a bunch of patients who go doctor to doctor to doctor to doctor, go back on and off, on and off, on and off. Because everybody a lot of work, but never stick around. And there's drug seekers, so those are 2 examples. Another one that came up was the College of Physicians and Surgeons told us we couldn't cherry pick. And by just taking diabetic patients, we were cherry picking. You're opening your door to certain patients. That's what and we checked with them because we were nervous. And they said, yes, you can't do that. So we fought them on that, and then they turned to their end. So we're actually right. But you're allowed to do it. You can open your door and say, I'll take it back to the patient. So that was January 2012, and by June of 2012, it was down to 2. Now I'd like to say we did that, but you never know, right? And it's really good in the rest of the province as well. So the number of unattached diabetic patients is really good. Increasing the rate of the colonoscopy follow-up. I can't give you any LHIN data on this. I can tell you that in 2008 the number was 63%. In 2010 it was 71%. Cancer Ontario was going through a horrible time with this because the data they send out to physicians, which you may remember, these little screen activity reports used to be sent out by mail. A few of them got lost in the subway. You're not allowed to send them out by mail now. Now you have to go on to the Health Ontario site, sign in with the secure password, and then you can see your thing online. So what we've been doing is encouraging physicians to sign in, which, to be honest, we haven't done that much.
Is that operational though?
I thought so, but today I heard no.
Okay, because I was going to say that I thought we were going to get a notice saying now it's time, and I haven't received that. I got my email.
Well, they actually had information, they actually had people going out there teaching or getting us on the system. So I thought it was operational.
I know, but someone came to me a long time ago.
I signed up probably about 1.5 years to 2 years ago. I still have not heard back. I emailed them 3 times. They said, it's coming, it's coming. I can't even get my ID.
That's annoying, actually. So, they're about to hire the regional primary care lead for the cancer system, the one the job I have. So hopefully she or she can figure this out. But if you do get it, there's a red bar there. This is a paper chart and that's circled, and it tells you how many people you have that have a positive screen FOBT but don't have a colonoscopy, and they'll give you the names so you can chase it down. Now, my practice, when I chased them down, I was surprised all of them have been referred. I had two, I think, who had been referred to a GI, but they didn't go. So they honestly felt they were back in. Okay. Actually, I spoke about this already. Our goal to improve the GP specialist referral system. Partnering for quality. So, how many practices, Rachel, do we have involved?
We have connected with 120 physicians, up from 74, I guess, a year and a half. We're 120 physicians.
Involved in this program. That's great. And you for the EMR?
Oh, well, that's
the same group.
Same group.
Yeah.
That's the same group. So we've got that's from initially, in the last 6 months, EMR support.
So the goal of all of this is to make quality improvement a day-to-day piece of our work. We don't actually, I don't do that now. It's actually hard work. But there are other jurisdictions in the world where that is just the normal. The first thing you do is quality improvements, and all the time you're trying to get your numbers up, improve things, and that's, I think, sort of a culture shift that we do need in Ontario. So we have the EMR support, more coming. Second coach just hired. We have a collaborative November the 8th.
One more thing
Yeah.
that's not listed there, so I realized that we're also holding mini learning collaboratives as well. I'm about to host that are both technology focused, but and separate ones that are QI initiative focused as well. So and those are beginning in mid-November and we'll run through to the end of March. So all of you will hear what comes to the both. So it'll be technology, EMR specific. So the first one will be practice solutions, the next one will be Carol. So
Yeah, it's good. So I can tell you when I go around I do open access talks to occasional practices, and I take Gina with me every single time so far. There's been all these EMR issues, and they just kind of jump all over you because it's great to have a resource to help pull stuff out. Do you want to say anything else here, Rachel?
just in terms of the learning collaborative, I think it's an opportunity for partners coming in, so whether it be the CCAC and aligned teams that are aligned already with their case managers, or teams who would like to link. It's an opportunity to make sure that the voice is heard. We will connect with the CCAC and they can align that case manager, do case reviews, review complex patients. If it's other community supports in the community, whether it be public health, mental health, we're there to try and make those links for you. Sometimes it's just a matter of knowing where to go. We're there to facilitate those partnerships and start the discussions within your communities.
And then one interesting little bit that's come up with this is John Thomas. So Dr. John Thomas from Lion's Head, he just loves all this stuff that we're doing, and he's on the primary care network. And he said, what we need to do as the primary care network is save a bunch of lives next year. That was next year. How can we do that? And so he came up with this idea of pushing the screening for abdominal aortic aneurysm agenda. Because actually there is evidence that, I don't think this routinely, but if you screen people with one ultrasound after the age of 65, male smokers is the big group, but actually there is some evidence for everybody. That you'll find some, and then they'll have operations and not die. So he's actually trying to work on with you guys a program where with each of the MRs you can pull out all of the male smokers over 65 to 75 who haven't had an ultrasound in the last 10 years yet, and CAT scans. We know that. It gets more complicated. That's what's interesting, actually. But one of those tests in that decade probably will save some lives. So and that's coming from John, which I think is really cool. Okay, and then and this is data from my practice from the Partnerships for Health, just to give people an idea of what QI means. So and then most of you know this, but basically you're tracking certain things. In this case, diabetic outcome measures, A1C less than 7 and such. And then with your team, you're changing the way you do team care, trying to improve these numbers through those PDSA cycles. So quick changes, see if it works. Doesn't work, throw away. Seems to work, keep going, and watch the numbers hopefully go up, not down. We still track these, even though we're up the partnerships for helping. And then finally, in terms of the primary care network, the open access scheduling. So I've done about 10 presentations around the LHIN. We encourage health quality in care as wave 5. So I don't know if you guys know about this, but health quality in care, a provincial organization, would, give you a coach you through this. Because implementing open access scheduling is very difficult. And if you do it incorrectly, you cause yourself a lot of work. So it's important to implement it. There's different ways of implementing it, but you want to implement it in a way that's not going to kill you. Because they could, and that has killed physicians. Because they say, I'm going to start open access scheduling on Monday, and it's Friday. And so they have the backlog to deal with, and they have all the new stuff, and they're there till midnight, and they say, this is a crazy system, and they give it up on Tuesday. So it's important, it takes a long time, and it takes, so the coaches will help you through all that. And I was pleased to, sorry, we'll talk a little bit about lean. So here's just an example of, these are emergency room visits in the various parts of our LHIN by county for arthritis complaints. And the blue, light blue and up are CTAS 4 or 5, which means could be handled somewhere else, non-emergent. So you can see that most of the visits for emergency room, for arthritis and for sore knees and that sort of thing, were felt by the triage nurse to be something that could have been handled in primary care. And there is evidence from our own LHIN that if you do open access scheduling, your patients going for this kind of visit decrease. And that actually can't be false. They did it. They looked at their own. Was that YouTube? No.
I didn't know, but she had that.
Yeah, it's really interesting. It was a great study. So she looked at. She looked at the your CS 4 or 5 visits. She implemented open advanced access scheduling. She looked at it again, and there was a significant difference there. So getting people, so when they say avoidable ER visits on the IHSP, this is really what they mean. Let people get into the doctor's office where it's an appropriate place to be. That being said, a lot of the LHIN, as I said, the rural part is patient-owned. Also, a lot of those patient-owned models are actually, the right place to be after hours is the emergency room. So it's not necessarily the LHIN. Sorry, go ahead.
I'm just going to add, like, this is arthritis data, but the interesting thing is, I would respect from the diabetes data.
Yeah.
Not only are these 4 and 5 showing up in this kind of volume, but it's during the hours from 8 a.m. to 4 p.m. when they're most prevalent, like 70% of everybody that's showing up as a 4 or 5 is showing up during business hours. So,
yeah.
What do we do with that?
And I think, actually another good study is Exeter recently, in their emergency, they looked at all the CTAS 4 and 5s, why do people come here? And 30% of the time, these are the people who presumably could have been seen somewhere else. 30% of the time was because someone told them to. And you wonder if it's telehealth, but a lot of times that's what they're told. A lot of times because they think they made a particular test, like a cast or an X-ray, so they go there. Or a lot of times they're scanning it. And that's probably 22% of those CTAS 4 or 5s according to the Exeter.
And the diabetes, most of them, they're showing up like those hypers and foot ulcers. And these are 4s and 5s. So, I mean, where else could they be going is a big question. Or, like you said, could they go to the doctor's office? Maybe they could get that morning. Maybe the messaging for them is, if I'm low, I've got to be in the ER.
Right. Yeah, but what else? The important thing that I push about open access scheduling is that although it's great for your staff because they have somewhere to put patients when they phone in, and it's great for your patients because they can get in, it's really great for you. It makes your day easier, you have less work. So the physicians who work 5 days a week and do 24-hour access scheduling, their workload goes down compared to traditional scheduling, even though they're seeing maybe more patients. And just quickly on the philosophy of open access scheduling, you max pack your visit, which means the patient comes in for a sore throat, you make sure they have the PAT, the blood pressure check, see if there's smoking cessation program, deal with their chest pain, deal with their blah, blah, blah. You don't book them for tomorrow, so you're screwing up tomorrow's schedule, you get it all done today. The reason it cuts down work is because you have on the top right here, you have your demand for visits, all the work that's coming in. On the bottom right is your output, and if your wait times are stagnant, so your wait time's 3 weeks, your wait time's 4 weeks, your wait time's a month, 2 months, it's the same, then you're actually keeping up. You just have this big pool of people who are always waiting. If your wait times are growing, then there's nothing any scheduling system will do for you. You're toast. You have too big a practice. You have to come back. But if your wait times are stagnant, which is most everybody, when I started this, I was a 3-week wait time. All it means is there's a big group of people waiting. You're keeping up otherwise. But this group of people causes all sorts of work. emerge sees them and sends them back to you. They phone, they want an x-ray, they want pain pills, they want this, they want that. And you're dealing with it, you're trying to decide where to put them in your schedule. If you had just seen that that work would go away, estimated savings for your clinic is 14% of your day if you get rid of that, according to Alberta. So your day gets easier, which means you go home and play golf, or you can take on more patients. So you increase capacity in your system without cost. So I was pleased to see that of all the practices that joined Wave 5 of Health Quality Ontario in 97, these are all the different LHINs. Our LHIN had the highest proportion show up for that. Wave 6 is in signing up is in November coming up, so I actually had all my colleagues ready to sign up for a group of 8, and they told us we couldn't. Because we're changing EMRs, and they said, oh, that's too much. So that was probably good advice, but I wasn't disappointed. So then we would have been at 25. So that's quality and access touched on there. Let's move to the hub discussion. So this is the hub. Now I've written up here on the top right, hub 1. So there's a number of different models. I'm going to show you the 3 main ones. This is the hub model put forward by the LHIN CEOs. This is the one we tend to be talking about when they say we're going to go to a hub model with accountability between primary care and the LHIN. So if we have 800 physicians in our LHIN, you can't have agreements, 800 accountability agreements between every doctor in the LHIN. It's way too complicated. So they looked at referral patterns through ICES data, and they've tried to put the province into groups or hubs of primary caregivers based on those referral patterns. So in each LHIN there'd be sort of 5 to 7, which puts us at about 100 to 150,000 patients per hub. And a hub would be a lead organization, in the middle there red, in this case a family health team or a community health center, who has an accountability agreement with the LHIN for care in that area. And they would be connecting to a number of different primary care providers in that geographical area. Community health center, independent practitioner, so like a fee-for-service doc, another full, et cetera, et cetera. So all those people would connect in to the lead organization. Now those are all similar sized organizations. So you could have, could be a CHC here. It could be one really big, huge family health team as the lead organization. Or in certain areas, and this probably works in some rural areas, it could be actually a hospital that's the lead organization, connecting the other primary care groups around it together. So why would they do this? So the lead group would be a leader in that area, would connect people, would help them share best practices, would potentially help them share staff. So if you're sorry, I forgot the term already. If you're a specialized family doctor, focus practice, then potentially you can share that focus practice across the hub. So that would actually help. You would align accountabilities to the LHIN. So the LHIN would say, in your particular hub, there seems to be an issue with diabetic readmissions or 24-hour access or whatever, and then you work together as a group to improve that. This isn't a financial arrangement other than there would be money for the administrative support for the large LHIN. It would be a voluntary thing. And so all of the existing contracts, so the FIT has a contract with government, that doesn't change. So what are some of the potential buy-ins for the guys who are going to be voluntarily aligned to this hub? Potentially access to interprofessional providers. So we talked about the haves and the have-nots. So this is an opportunity maybe. So we have, for instance, in our FIT, a nurse practitioner who does a really great job with seniors care. She does our any mental status exams, and she does our, a lot of our depression screens, and she follows them up. It's really good. She used to work in a geriatric program in Kitchener. So potentially that service could be opened up past our FIT doors to some of the other practices around who don't have access to such a great service. Coordinated quality improvement activities. So we just talked about how the partnering for quality, it's complicated, it's EMR data, it's PDSA cycles, like it takes a bit of work. A lot of that work's been done over in this FIT. So share that around, share it around locally. What did you do? How can we, that seemed to work for you, we should do that. So there's a lot of sharing there that could be used by the other practices, especially those solo docs who don't have access to a lot of the resources that we have. For instance, in our FIT, we have an IT resource, someone who helps me mind my data. A lot of people don't have that, that could be shared. So that would avoid duplication, make it easier for more people to participate. And then the back office stuff. So, and I don't know, our FIN really used this from our FIT. So doctors don't tend to be that great as a rule with stuff like human resource contracts for their staff. And so by hooking up with some of these groups that have a lot of that expertise, you could just share that information and improve things in your own office. And that's just all voluntary. That just makes a lot of sense to connect people locally. Potentially, you could share on-call services. So this might work in London, for instance, pretty well. So we have a big group. You could add people in and say, now we have our particular hours of call we're supposed to cover. So we can do a bigger group because we're in one of these hubs. So you could talk about it. You can engage other people. So the hub concept makes it a lot easier to have discussions with how CCAC, for instance, works in particular on particular issues. If there was a palliative care issue in your area, for instance, then the hub could discuss that and you could work together. You can have, encourage everybody to meet your CCAC case manager, know who it is. Does everybody know who their case manager is? Do you meet regularly with their case manager? Oh, it should have happened yesterday. So this is one thing we really encourage, is to actually get to know that person, and the hub model would actually encourage us. And it'd be good to do that now, because you'd be surprised who isn't on our list. I'm actually surprised.
Just for the London.
Yeah.
There is one. They're starting slow.
Right.
They're starting slow. Because there's 10 docs now all under the same roof. They're starting slow with 1 or 2 docs to make sure the bugs get worked out and moved on.
With the London taking?
Yeah.
Okay.
So it should be coming.
Okay.
I don't know, it's one of those things that's just very believe it takes so much time. So there's no need to revise these contracts. So in our LHIN, for instance, we feel we can start to do this hub building without legislative changes by just starting to connect people locally, the primary caregivers together, and then I think naturally out of that, connections with CCAC and with other organizations, local community caregivers will be encouraged. You can use data. So the whole point of the accountability group is the LHIN can take data from that hub and make suggestions, try and make improvements, and then get that data to be improved. So it's kind of a working together, collaborative model, LHIN, primary care groups. It gets us all sort of more together, working on the same page, sharing the same goals. So we're participating in system planning. Similar to the primary care network, this is a way of engaging primary caregivers in system planning. We're operating as stewards, and we're working with LHINs to establish 1 or 2 targets. So that is, in a nutshell, what people are talking about in general when we're talking about the hub model. I know a lot of you were here today to talk about this. So did you get point 1?
Yeah, we're understanding it better, I think, than we did previously.
Otherwise, I think I heard some other.
Do you have more to say about
Yes.
on this? Did
Yes.
you say there is a different type of model that
Yes.
was being?
So I have 2 more hubs to show you, but this is sort of the one we're building. We're hoping to build, and I think where most of the energy is eventually. As I said, we're not really sure where things are going from the center, but to us, there's a lot of benefit to this, even if nothing happens provincially, to starting to build those connections and drive data at a local level to try and make improvements. Some of the questions I have about it are, how does this, will this work? Will there be enough buy-in and enough value added for those groups around the center one to join in? So it has to be a value-added proposition for everybody involved. I think there is enough there to do that. And the other one is, let's say another group wants to hook into this. So you have public health wants to do something, or Cancer Ontario has an issue. Do they go through the LHIN to get into this, or do they go in through the networks to get into this, or how do other groups access primary care It may not be a local thing, it may be a provincial thing. So, there's some issues like that. But I think this helps build a real good base for connecting with primary care and starting to develop accountability and quality improvement initiatives at a local level.
Are you looking at this as a voluntary type of
Yes.
system? Okay.
Maybe someday money will flow, but there's no, that's not.
Right, so voluntary. And then in terms of sharing of resources, in terms of, actual, access to certain allied health professionals, how do you guys see that happening, given that that complement for the team was based on the roster of patients we already have? So if you start expanding the number of patients you're planning to sort of use this person for, then no one will have access, because there's not enough hours in the day for that person to supply or to service, the triple amount of patients you've just added.
Right, excellent question. The answer is that is one of the legislative barriers right now to implementing that part of it. That our family health team isn't really allowed to share their resources. Well, to be honest, we do. We share with the hospital, but you're not supposed to. You're supposed to be. You're paid to do that group of patients, and I think things would have to change centrally to allow that.
Actually, Rob,
You can. Okay, so we should.
positive.
We went through this discussion.
We went through this discussion with
Ministry
the highest
representatives.
level, and they said you can.
But who do you share with?
You,
Theoretically, anybody you want.
anybody.
Okay.
We actually have a situation in our fit
Uh-huh.
where we are doing that at the present time. And we thought we were doing this outside of the legislation, et cetera, but we were assured that, in fact, what we were doing was well within legislation. There is no restriction of doing it. The question then,
I'm not so worried about the legislation,
Right.
actually.
but the question then is your question.
Yeah.
Which is very much, so you have, 10 social workers in your
Yeah.
hub. You now invite, 10 fee-for-service practitioners, and you say, okay, you can share our social worker and our pharmacist and our diabetic program and whatever. So then your roster patients who now wait 2 weeks to see the social worker now has to wait 10 weeks to see the social worker. Right? So how does that work? Like, how do you envision that working?
They talk about different personality types of meeting. Some people are up here in the big thing, and some people get put in the doctors tend to be the work, the details, right? So I don't know. But the point is, with the bigger picture, makes sense, and a sharing of resources in a way that is going to help people and not spread them so thin that nothing happens. So you can't just open the doors, the floodgates, and have 10 million people. I hear what you're saying.
Right.
When the group, the lead organization talking to everybody is looking at sharing resources, if that's where they get to, then it has to be done in a way that makes sense. So in our, actually we do this too, that nurse practitioner I was telling you about, she actually works in the hospital to help improve the care we give to the people in the complex continuing care. And then in the community, she sees them. But she's not paid by the hospital. And she's not privileged, actually. It's kind of a little lacy, right? But that makes a lot of sense in terms of crossing those barriers that are there. So, you guys would have to work that out. But it makes sense.
So so then is that something that the hub works out? That we figure out, we have this thing that we can offer you, not you tell us you have to offer this. Do you know what I mean? So it's a very different idea for me that, the hub, we sit down and we say, okay, we want to be a hub. Let's say you want to be one of the leads or whatever that red group is. You have to sit down and see, okay, we're maybe heavy in this resource, and we can afford to branch out or let some of that, or open it up to more people. But I guess what I was envisioning when I start hearing hubs, and this is where the ministry is going, I start hearing the ministry is going to say, you have 2 social workers, and now those 2 social workers have to work for 10,000, more patients with the same amount. That's what I'm worried about, that it's going to come from above saying.
That's not what I'm saying.
Okay.
That's not what I'm hearing. What I'm hearing is, and I think we have to bring CCAC into this, is as a hub, you say, look, we have lots of people who are
Okay.
getting their mental health needs met.
Right.
We have 2 social workers with this fit. We have all these mental health organizations doing this stuff. How do we maximize all these resources
Okay.
to improve that situation? So, so it's not just sharing fit resources, but it's
No.
actually connecting to community services and all those other resources
Okay.
as
That's
a locally connected group.
Okay.
Yeah.
It's really that virtual team with the resources in the communities, whether we, like in London, they've got Watch and Search, right? So I don't know other acronyms for mental health, but how do they fit into the picture along with the social worker?
Mhm.
How do the CCAC in-home social workers fit in? Because they'll see folks in the home for specific reasons. So it's really finding that common ground and leveraging each other versus how to serve everyone, I think.
And right now in Listowel, we have a deck in the hospitals, with a nutritionist and a diabetic educator. And then we have a nutritionist in our fit across the street. So we're actually overloaded with, it's great service, but there's probably, if you were to look at that system-wide,
Right.
maybe there's ways
Yes.
that could be actually
I see what you're saying.
shared a little better. So I imagine a lot of fits are like that. They got tons of something and then not much of something else. And the other thing that would happen actually in the hub models, we said, look, nobody has access to mental health services here. This is crazy. And then the LHIN kind of steps in and helps organize that. So it might be bringing resources into the hub.
And to speak to that as well, I mean, with DECs, they are not at capacity. There is capacity available at diabetes education programs, and they're constantly looking for new clients because they're not meeting the targeted thresholds that they're supposed to be meeting. So they're trying to build relationships with family health teams or sole practitioners. It's just they don't know how to do it, and they're not necessarily funded for the outreach piece, right? So I mean, from an RCC perspective, we're trying to help build those relationships so that folks like the family health teams can leverage those additional resources that are already being paid for, and they have the capacity. So I mean, I think it goes both ways.
Those decisions, they have to involve the people who are providing care in those local areas. So that's what this sets up, is a mechanism to have that discussion system to smaller systems. Good discussion. Okay, so that's number 1. Just to be thorough, though, there are other visions of what these will look like, and we're not really sure. So there's something called a patient care network. So this is what I call the mini LHIN. So a LHIN is the bringing together of all the different healthcare players trying to work as a system. In this case, the hub would be a collection of all the healthcare players in an area working together. So that would be hospitals, specialists, community service providers, CCACs, in a patient care network, and you'd have 5 or 6 of these maybe around the LHIN. My worry with that is that primary care gets a little bit lost in there. We're still unorganized in this, I think, in this model. I prefer it if we can organize primary care, and I think the rest of this would kind of follow afterwards. But this has certainly got traction provincially in this particular model. I'm not as sure about, talking about the details how this would actually work. I have more trouble wrapping my head around it. Like, is there a board here with everybody talking together? I'm not
This is
sure.
just another board. What happens then?
Actually, this is what my family health board is like. We're a blended model. It's kind of neat. It works. That actually does work. Actually, if you have a group of all these people. But still, I think primary care needs to be organized, and I think you lose that here. But this is one potential outcome. And then the third one, this comes from the conservative paper on healthcare. And what they suggest lots of things, but they suggest that these local hubs be controlled, isn't the right word, coordinated by the hospital corporation. I don't know if people have any, does it terrify you, or does it seem like an opportunity, or what do people think?
I think as a small team in a large center, my worry would be that sort of these grumblings that I'm hearing that I'm going to be swallowed up by a bigger team at some point and lose my autonomy as a small team. And I think out in the communities, in the smaller communities, I don't think there's that big of a worry, since you are, like you're kind of like we're separated by space and geography, but in a large place, large center like London, that's something that worries me about this idea of the hub. And so then, I don't know, what's best for the patient, what's best for me, I'm not sure.
Right.
I'm not crazy about the hub model, but I also see that there could be some strength in sort of the model you suggested. I'm not sure that the second model shows me anything useful, and certainly the third model has nothing to offer. Sorry. That's my thoughts.
For what it's worth, Rob, I think your model, the first model, I think I could see how that could work.
Yeah.
So of the three, I think that's the one that we would like to pursue. I think you kind of hit on a couple of things that have been important. It's sharing resources, but also you've got to have some incentive for the not the red lead team. You have to have some sort of incentive for the others to kind of join up. And so I think by having thought that one through that far, it goes much further than these other ones do already.
Yeah, I think there'd be a real opportunity with that model to, I just agree with you. That model, I think it just brings people together. And then you can start to say, what's the best thing we can do for this area? So we're thinking a little bit bigger than our own office or fit now, a little more systemically. And then with data that the LHIN can help us get for that area, you can have focused interventions to try and improve care for people in that area. So do you agree?
Yeah, I mean, I think a hub model can, and in fact does work. I mean, 10 Valley Family Health Team is essentially a hub model. We have 11 FOs in 4 counties, 3 counties plus the city of London. When we came together in 2007, our biggest concern was that London would take up the lead in all this, and they were going to be the big player, and all of the small communities were going to get nothing, and so forth. Then we were worried that the academic centers who were associated with it were, because they had all the administrative folk and already knew how to function in teams, that they would take over. And I think as a working model, it works very well. We too have a blended governance model where we have various players as part of our board. I think when you have a board that very much thinks about what's best for the patient as opposed to what's best for each individual physician group, it really is helpful. All the groups will not buy in the same. So some people will want more of one or less of another. We have, at our site, for example, leveraged DEC as our sole diabetic care. We do not leverage any of the FIT money for diabetic care in Strathroy, Ilderton, and Mount Bridges. That's all done through DEC. Other places, it is all done through the FIT. So, we kind of look at each center and kind of say, well, what do you need? And so it really is, in essence, a working club model. I think it can work very well. My concern, I guess, would be that when we start to take places that aren't our rostered model, how do we get CCAC, or how do we get search, or how do we get watch, or all these sorts of things to sort of give up their little pile of money that has been for a certain social worker or certain nurses or PSWs or all those sorts of things. Who makes that ultimate decision about we do need to start to bring these social workers from either the FIT to watch or vice versa? Who makes that decision? So if there's not going to be any actual money that comes in, then who makes the decision? Who gets the final say? Because I don't think the CCAC is going to give up their X number of millions of dollar budget and sort of say, all the social workers can come under the FIT. Not voluntarily anyway. Right? So how does that happen?
I think I'm missing it, but the answer, you sort of said you guys are like a hub now. So how do you decide how the resources get shared around that?
Well, the resources are decided by the number of rostered patients that we have, as you pointed out. When you have a certain number of rostered patients, then the FIT gets a certain budget.
I mean, you're on different sites.
Yeah.
So where does the social worker go? Where does which patients actually?
So that's allocated by a model that we have agreed to at the board level to sort of say, you know, this is the policy and how we're going to try to distribute social workers or whatever. And then we go to the actual site and say, you know, this is what we were thinking about giving you. What do you think? Is this something that you need, or is this something that you don't need, or you need more of something or less of something else, and you can kind of trade so that in the end it's sort of equitable for the patient population.
I think, and maybe I'm not hearing your question, but I think the hub would be very much like that. You'd sit as a group, say, these are the resources we have, we talk to these guys, and then you talk to the leaders out there and say, look, this is what we're thinking is what's best for the patients in the hub. This is the way we would share them, and then that's, you decide to do that. Or am I missing?
I don't think we'd be in control of CCAC and sort of say to CCAC,
No.
social workers or PSWs, you know, I think you need to come here. You know, CCAC would say, well, no, you know, right now we have this initiative going on home first in the hospitals, and, you know, I think we need it all over here.
Maybe it's not a control thing, it's a coordinating.
It's a coordinated approach.
Look at the patient care network, the second hub model. That's where you've got the ability to transfer resources between the different providers. In addition to primary care, you have a watch and search at that table as well, saying, well, we need some of those resources in the fit. How do we get those over there? We could do it right now at the LHIN level. It wouldn't be as neat and tidy as when you have a smaller geographic area. But if the fit's saying to the LHIN, you know, watch, you got to give up some of your resources because we can really use them in the fit here. It would make more sense. We could do that analysis and say, yeah, it does. So let's transfer some of those resources if primary care comes to the LHINs. So the opportunity does exist now to do that. It just wouldn't be as easy as if it was in a smaller geographic network.
I think from what we've seen is appetite for those partnerships, so those non-formal partnerships to happen. Just getting ready for our learning collaborative next week, we've actually had really good response from the Canadian Mental Health Association and Public Health and just wanting to start better discussions with primary care in terms of how can we help you. I think people are at a point where they're really wanting to start discussions. How do we do things differently? Because change is afoot. With CCAC case managers, it's the partnership piece. It's not a matter of we're going to plunk someone out and you know it's your resource. It's that partnership piece and how do they work as a bigger case management team to support primary care across the Southwest. And we've seen some really great successes in terms of you know avoiding hospital admissions for really complex patients, and that care coordination happens a little further upstream than a crisis moment like on a Friday afternoon. But it's that virtual team partnership, it's the willingness of folks to change the way they do things. It's not easy work.
And I think a good example of where we have done it is it's not switching resources from one place to the next, but it's not that you said to the DAG, we need resources at the Strathroy Flow and give us the resources. It's, you said to the DAG, we need resources at the Strathroy Flow. Bring your resources here and we'll work with them. And the same thing we do with like the Arthritis Society, the Senate sites, that kind of thing. So it may not be about a reallocation of resources, but that cooperation. And so take the resources where they need to be, regardless of who has responsibility for the budget. So that's a way of doing it without the funding going with it.
But you have to be sure of that allocation before you take on 10,000 more patients. Right? I mean, that's the thing that I worry about.
Yeah, and I think, especially for the resource-rich fits, that would be my worry. I can understand that. I don't think the goal is to deplete resources from the places that have it, but to share them more equitably, I guess, which is maybe into the same thing I'm not sure. Yeah, but you were able to do it. You work out ways to do it in an equitable way in your large group, and that made sense for patients. So I think that's the goal. But I do think it's just fair that the resource-rich teams probably do need to share to make things better for the system. I think that's a fair comment. We only have a few minutes left, and what I wanted to do was really just make the point. Let me get back to where we were here. That a lot of what the LHIN is hoping to do, and a lot of what the province is hoping to do in terms of primary care improvements, is really what the Canadian College of Family Practice wants to do, which is encourage the medical home model. The medical home model is all about having a comfortable place for people to have their healthcare needs met. I think community health centers have nailed this. People want to go there instead of emerge. It's a comfortable place to go. They know they're going to get access, quality, all those things that we can measure. So in terms of engaging physicians, this is something that really our bodies promote to quality, access, accountability. That's in the medical home model, and so really we should be on board with those things. And I actually think people are. I don't hear too many people saying they're not interested in quality improvement. I think most of us want to do a good job and want to do a better job, and actually know that we're doing a good job and go home at the end of the day feeling like we took care of patients. That people got in to see us and we helped them. And that's what's really what we're there for. So that is the vision of the Canadian College of Family Practice. Just quickly, what a medical home is, in case you don't know, a comfortable place to discuss healthcare concerns. It's a hub connecting people to the larger system, and coordinating through that. Not to take away from CCAC that they, you connect with the connectors to do this. A place that listens to and respects people. It's a bit soft, I know, which is good because I think we need it in primary care. Therapeutic relations are developed. And you hear people say, I want to go to the doctor who knows me. And I want to go to the person who I have a relationship with. And that actually counts a lot for patients. It's a part of the healthcare system where people feel most comfortable. And it is something that's measurable. And it's a lot of these issues that we're talking about. So you can measure things like patient-centeredness, team-based care, timely access, we talked about open access, continuity of care, using electronic medical records, not just to do games or paperweight, but actually to pull data out of your defined population, health professional training, participating in continuous quality improvement, so making that part of our daily job culture, and supported by the province and the LHIN. So I really think that this is somewhere where all of this meets, and we were fortunate. I enjoyed the presentation of Kathy Ball's practice, London, and I got that right with as a medical home. So we picked a few criteria. She met them, did a bunch of these things, and that was celebrated. That we have a lot of this going on in our LHIN right now, and I think we need to celebrate that. Comfortable place for people to get their healthcare needs met. So thank you very much.